Good evening, everybody. My name is Roxanne Chabot from RBC Consultants. Thank you for joining us this evening for another Skin Chat webinar. The topic of our webinar this evening is choosing the right partner, complementing prescription medication with over-the-counter cleansers and moisturizers. As presenters, we have Dr. Leon Kurcik. Dr. Kurcik is president of the International Dermatology Education Foundation, as well as clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York and Indiana University Medical Center in Indianapolis, Indiana. He is also medical director at Physician Skincare, Derm Research, and Skin Sciences. We also have joining us this evening Dr. Kanukvale Kulthanan. Dr. Kulthanan is professor of dermatology at the Department of Dermatology, Faculty of Medicine at Ceramide Hospital in Mahidol University, Bangkok, Thailand. She is also president of the Dermatological Society of Thailand. And we have Dr. Ted Lane, who is a board-certified dermatologist and chief medical officer at Sonova Dermatology. He is also executive director and principal investigator at the Austin Institute for Clinical Research. We'd like to thank our supporters this evening, Cerave, that have made this educational event possible. Couple of tips before we start our webinar. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you'd like to ask a question to our faculty, please submit your question in the question chat pane on the right-hand side of the screen. And I wrote a little note there for you so you can see where it is. At the end of this webinar, a survey will pop up in the browser and it will be emailed to you 1 to 2 days after the webinar. We would greatly appreciate it if you could fill in this very short survey. Finally, within 1 to 2 days of the webinar, the recording of this program and a certificate of attendance will be emailed to you. Once again, please ask your questions and submit them in the question chat pane on the right-hand side of your screen. So without further ado, I would like to pass the floor virtually to Dr. Leon Kurcik.
Thank you, Roxanne, and greetings everyone from Louisville, Kentucky. So for the next 10-15 minutes, what I'd like to do is to go over the epidermal barrier, the principles of understanding the epidermal barrier so that we can understand how we can choose the right companion for our acne treatment. So the important concept here that I'm going to be discussing is really the pH and how does the skin pH function and how it interacts with the skin barrier, especially in inflammatory skin conditions. But I'd like to start with the relevant topic of COVID. I think we all know the cutaneous manifestations of COVID. We are all familiar with it. We know the direct impact, especially the COVID toes that we keep seeing them. It comes up in the dermatologic literature. But what's interesting and what I want to concentrate on today is the indirect impact of COVID. And really that comes from all the personal protective equipment that we are wearing, especially the masks and the shields. And honestly, that was relevant first to us, to healthcare workers, right? The doctors, the nurses, all the healthcare workers. And the result was that this is what we see, especially on the face. And the very first reports came actually from Wuhan, where the pandemic started, how the healthcare workers' skin was impacted by wearing the gloves and the mask, and especially the masks on the face. But I want you to think of this. How about the acne patients wearing those masks? And this is what we're going to be discussing tonight. This is our topic. How does that epidermal barrier functioning in acne patients, and what can we do to make the treatment easier, more tolerable, and palatable for the acne patients in this case? Now, but by this time, as the pandemic unfortunately going on, now it's not only the healthcare workers who's wearing this mask. All of us are affected. The whole world is wearing a mask, right? So that means everybody is impacted, including our acne patients. As we know, the public health commitments of COVID is wash hands, wear gloves, wear masks, wear shields, and those are all occlusive on our skin, which is not going to help the epidermal barrier. Everything that we're going to be discussing is relevant without the COVID, but really it's becoming even more important, more crucial, considering the indirect impact of the COVID on our skin. And that brings us to the role of the pH in the skin barrier function. Why is that important? Let's take a look first. Think about what is the normal pH of the skin. The normal pH of the skin is somewhere about 4 to 6, mostly around 5, 5.5 on the acidic side. Okay. Now, when we wash and use a soap, just a regular soap to wash our face, and by the way, acne patients do that quite a bit, right? Because they think that the acne comes from dirt. They want to clean the face and use harsh soap. Guess what? That pH is 10 to 12. It's quite basic, just the opposite of the neutral pH of the normal skin. Even if we don't use soap, I tell my patients soap is great, but don't use any soap. It's not good for your skin. Tap water pH is 7 to 8.5. It's still on the basic side. You wash your face with just regular tap water, you are actually increasing that pH of the skin. Normally, that's about 4 to 6. So what happens when you increase the pH? When you increase the pH, inflammation, decreased stratum corneum cohesion, definitely epidermal barrier disability or dysfunction, decreasing the permeability barrier. So, and that in return is going to increase irritation, cause dryness, itchy skin, which already our acne patients are experiencing with the medications that they are using. I want you to think about just the topical retinoids and what they do to the skin. So let's take a look, a little bit of a closer look, deep dive into the stratum corneum in order to understand the importance of the pH. Stratum corneum is formed of the brick and border, keratinocytes or corneocytes, as well as the lipid matrix. So the lipid matrix that holds that epidermal barrier intact is very important. But also between the corneocytes, we have the corneodesmosomes. Those are sort of the nails holding that brick wall together. If you sort of mess up with that nail, then the corneocytes will be loose and the wall will be loose, and you will have more epidermal barrier dysfunction. So let's take a closer look what I mean with that. But the lipids, there are three types of lipids. 25% about of them are cholesterol, 10 to 20% fatty acids, but the chunk of it is ceramides, close to 50%, and we're gonna concentrate on ceramides today. So where are those ceramides coming, and where are those lipids are coming? Are they there ready-made? No, it's not. They come from what we call precursor lipids. For example, glucoceramide is converted to the ceramide by an enzyme called beta-glucocerebridase. So the enzyme here is the rate-limiting function of that conversion of the precursor ceramide to the ceramide. The same way all the other lipids, phospholipid by phospholipase action becomes fatty acids. Cholesterol comes from cholesterol sulfate by steroid sulfatase enzyme. The bottom line is to understand that the enzyme that converts the precursor lipid to the final lipid is very important. So let's take a look now what happens at the healthy skin. We already know that those corneocytes are full of natural moisturizing factor, which comes from filaggrin, and filaggrin comes from the profilaggrin. And we know that atopic derm patients, certain inflammatory diseases, genetically they are short of filaggrin. But then let's take a look here what happens at the lipid lamella, right? As I mentioned, that the lipid processing from the precursor lipid to the let's say in this case ceramide is dependent on the enzyme glucocerebridase. Guess what? That enzyme activity depends on the pH of the skin. At acidic pH, that activity is normal. But if you increase the pH or decrease the acidity just at 7.4, which is tap water pH, the enzyme that converts the glucocerebridase to ceramide, beta-glucocerebridase, that's the name of the enzyme, it functions 10 times slower. So what's happening? Your ceramide, you're not making enough ceramide because of that pH, because the enzyme, the converting enzyme, is not functioning normally. It's lazy. It's slow at a higher pH. Does not like the higher pH. Here's number one. So your lipids are not being made, specifically the ceramide. And now your cement, your mortar between those bricks are not there. Now, remember I also mentioned the corneodesmosomes that holds the bricks together. So you can say, why do I need the mortar? Because anyway, the wall is okay, intact there, because the nails are between the bricks are there. Really? Maybe not. Because those corneodesmosomes can be broken down by degradatory proteases, by enzymes that literally break the corneodesmosomes, such as kallikrein 5 and 7. How do they function? When the pH goes up at a basic pH, also those degrading enzymes such as kallikrein 5 functions much better. So here we have another problem. Now pH went up, so what happens is these degrading enzymes of the corneodesmosomes are happy, active. So they are breaking down the corneodesmosomes. Now you have double whammy. Basically, you're not making the mortar and you're breaking the wall and the nails, so the wall is gonna break. Once that wall breaks, the trouble starts because the invaders are gonna come. Your fort that you had is not there anymore. It's easy to penetrate. Who's gonna come in? Staph. By the way, other stuff too, right? Virus, fungus, you name it. Everything is gonna come in, as well as the allergens. That's how people develop allergies, right? But here in this case, what's relevant to us is that the microbiome of the skin is gonna be messed up. And more of the Staph aureus is gonna come, and the regular normal microbiome of the skin, the ratio of gram negative to gram positive is gonna increase, and that's called dysbiosis. By the way, Staph aureus, they love at higher pHs, at neutral pHs. They drive at neutral pHs. So if you have an acidic pH, the Staph aureus is not gonna coming in. They don't like it. The regular microbiome likes the acidic pH, but pathogenic bacteria such as Staph, they thrive at neutral pH levels. So basically, by washing your skin by tap water and make that skin pH neutral around 7, you're inviting Staph in. So just think about that. There is actually CDC report that says that we should not be using soaps associated with long-standing changes in skin pH, leading to reduction in fatty acids, and then, more importantly, that's why CDC actually gets involved, subsequent changes in the resident flora, which is the last thing we want, because we don't want to disturb our regular microbiome. We don't want to disturb the resident flora. We don't want to invite stuff in. So changes to the microbiome and decreased antimicrobial capacity. So it's a problem with the pH changes. We want to keep that skin pH at acidic level. It's neutral pH of the skin. So I'm going to stop here, and I'm going to give the floor my good friend, Dr. Ted Lane, who's a board-certified dermatologist and chief medical officer of Sanova Dermatology, and also the executive director and principal investigator at Austin Clinical Research Institute. He's going to tell us why and how to choose that right partner with the acne patients. Thank you, Ted. Take it from here.
Thanks, Leon. What a wonderful presentation to understand the importance of pH with all of our skincare products, right? We want to maintain the acid mantle of the skin. And so utilizing the correct cleansers and moisturizers is so important. It segues so well into this talk, which is choosing the right partner, complementing prescription medications with over-the-counter products. So before we begin, I'd like to start with a polling question. This is really interesting to me because this is something I do all the time. Do you routinely suggest over-the-counter products to your acne patients? And it's a simple yes or no. If you don't mind inputting your answer, we'll get the results in just a minute. It is something that, since I've learned about the importance of over-the-counter skincare and really dived into the data, this is something that's really become a huge part of my practice now in terms of the time I spend with my acne patients, the writing down the different regimens after I've looked at their skin. So this is great. So this is very encouraging. I think all of our speakers would agree this is very encouraging. 3/4 of people here say yes, and 1/4 say no. Well, hopefully after today's talk, we'll get to 100% in the yes. So today's talk really is derived from a paper I wrote that was published in the JDD in November 2020 with the same name as this talk, where I've tried to come up with a couple of decision-making frameworks so that you can use this if you think it's appropriate for how you think about utilizing and recommending the over-the-counter skincare for your patients. Because when I looked at the shelves that contained my acne medication samples, I realized that I had a great framework. I really understood the data, and I understood which patients would do well with different acne medications. I felt like I had that down, okay? And I'm sure all of you listening do as well. The problem came with this. When I looked down at the bottom where we had all of the skincare samples, is it all marketing or is there science there? Was there a way for me to figure out and determine which one of these would go well with which patient? I needed to figure out a way for me to utilize what I had with the prescription samples and apply it to over-the-counter skincare samples, and that's where the whole talk comes from. Now, Leon touched on this. The barrier integrity in facial inflammatory diseases the problem is barrier integrity, of course, and we look at functional and structural issues. We know that especially with acne, we have increased sebaceous gland size and sebum production. Now, the issue, of course, is that the sebum is altered. It's actually pro-inflammatory. It's high in squalene, for example, which we see on the other side and that under structural. And that squalene metabolites, when they're oxidized, are pro-inflammatory, which does nothing except lead to lipid peroxidation. And I think we're all familiar with the lipid peroxidation hypothesis of acne, where the increased peroxidation leads to pro-inflammatory byproducts, and those lead to an increase in inflammation in the skin. Now, structurally, we see an increase in filaggrin and the profilaggrin to filaggrin. The filaggrin then leads to hyperkeratinization itself, but we also see reduced free fatty acids, which Leon talked about as well with the increased pH, ceramides, and free sphingosine. We talked about the increased squalene and oxidative metabolites. Another thing that's interesting is the increased toll-like receptor 2 expression. Toll-like receptor 2 is somewhat of a signaling protein between the microbiome and your own immune system. So toll-like receptor 2 is very important. It's a pathogen sensor also. So toll-like receptor 2, do not discount, because I think we'll see a lot more data coming out about the importance of toll-like receptor 2, and I think its importance will be harnessed by skincare in the near future, much like toll-like receptor 4 and 5 has already. Okay, so when we think about the goals of skincare regimen in our acne patients, we need to remove the altered and pro-inflammatory sebum, as I just mentioned. You know, Yamamoto showed that there was a reduction in ceramides in the Stratum Corneum despite this increase in the sebum. So he also showed actually that there was altered ceramide content in the keratinocytes, whether they were in the inflammatory aspect of the acne or between the inflammatory lesions. So it's a really important paper actually. But we know that the sebum doesn't have the correct amount of ceramides. We know that the keratinocytes are not producing the correct amount of ceramides. So replenishment of ceramides is key for our acne patients. Repairing the barrier, therefore, is super important because barrier dysfunction correlates with the hyperkeratinization and the comedone formation. So we must remove the excess sebum and debris on the skin surface, but we must also leave those intracellular lipids that are so important to the skin barrier intact. So we have to remove lipids on the top of the skin, but leave lipids between the corneocytes intact. We also have to improve the skin barrier through moisturization. So those are our goals. There's another thing that we can look at, and that's clinical trials, because we can see how just by using barrier repair, how that can affect acne's progress or lack thereof in patients. And in fact, when we look at clinical trials, especially the phase 3 trials over the last 5 years or so that were done with so many different topical medications, there always is a vehicle arm, right? Which includes the vehicle base, which can itself be moisturizing and hydrating, a separate moisturizer and a lipid-free cleanser. We're involved in numerous acne trials, and we're forever giving patients Cerave cleanser, for example, Cerave lotion, and the vehicle base. And that's, of course, as compared to the other group in the trial, which has the active medication. So when we look at just this vehicle arm, we know that what's happening is purely barrier repair, and yet we see consistently a 40% inflammatory lesion count reduction at 12 weeks. I challenge you to go back and look at the phase 3 results, the pivotal results of multiple different topicals, and you'll see consistent 40% reduction in inflammatory lesion count reduction. That is attributable solely to barrier repair, hence the importance of over-the-counter skincare when you are prescribing something for your patients as well. In fact, 11 Canadian acne expert dermatologists published a consensus statement that showed that ceramide-containing moisturizers may enhance adherence and complement existing acne therapies. They call it adjunctive therapy. Do you see that there? Adjunctive therapy. So they are actually listing this as therapy. And I think that's how we should consider it as well. It is no longer something that we should just no longer pay attention to and just have our patients use whatever they would like. I challenge you to consider the over-the-counter products as adjunctive therapy to your prescription products, because it will improve outcomes. Now, when we're thinking about moisturizers, I'm going to just talk about some of the basic characteristics of moisturizers. One is occlusion, right? So our moisturizer's goal is to seal in the water. It acts as a film on top of the stratum corneum to seal in the water and therefore prevent loss and repair the barrier. Common ingredients are listed there. We know that a 5% concentration of petrolatum reduces transepidermal water loss by greater than 98%, but there are other common ingredients involved in occlusion as listed. Oil-free moisturizers, including those ingredients like silicone and dimethicone, reduce transepidermal water loss by much less, by 20 to 30%. So you'll see other ingredients besides silicone or dimethicone in the oil-free moisturizers as well, because of course our patients are not going to probably accept a 5% petrolatum. Although it's non-comedogenic, it's just difficult to use. Then we have humectants, and humectants' main role is to draw moisture or hydration into that stratum corneum. We thought initially that humectants were drawing water from the environment, but actually they're drawing water from the deeper layers of our skin. Unless the ambient humidity is greater than 80%, maybe Dr. Pultanon can see that where she is in Bangkok, but certainly here in the United States, it's difficult for us to consistently have an ambient humidity of 80%. So most of the moisture will be stolen from lower layers of the epidermis and dermis. Examples of humectants include glycerin, hyaluronic acid, and you see those. And honestly, we need to consider urea, less than 10%, a humectant as well, and you'll see that in some of the skincare products. Emollients. So emollients are really for the feel. This is patient focused, okay? Emollients make your skin feel better. It gives you that smooth feeling to the skin. These essentially plug the gaps between the corneocytes. So they replace the mortar in that brick and mortar model that Dr. Persick mentioned as well. Cholesterol, squalene, fatty acids, glycosylceramide, these are emollient ingredients. So here we have the barrier repair as well. And when we think about barrier repair, we think about replacing the physiologic ratio of ceramides to cholesterol to free fatty acids. You can see it's a 2 to 1 to 1 essentially ratio. Remember that ceramide is nothing but a fatty acid with a sphingosine base. When you see phytosphingosine, for example, being added in skincare, that's providing that sphingosine base to form a ceramide. We know that ceramide 1 essentially is the signaling ceramide. It conducts the orchestra for the other ceramides. Ceramides 3 and 5 are in high concentration as well in that lipid bilayer. You'll see in the Cerave products, they have 1,3, and 6,2. 6,2 is also in high concentration in that lipid barrier and plays an important role as well. Okay, so as we go into our specialized moisturizers for acne, I'm going to go through a few of the products that I used in the paper. So Cetaphil Pro Oil Absorbing Moisturizer, the oil absorption comes from that silica and the aluminum starch. It has emollients, it has humectants, its anti-inflammatory ingredients include licorice extract and zinc gluconate. We all know that zinc is also an antibacterial ingredient. It has the ceramide technology where it has a pseudoceramide mimicking ceramide 5 that attempts to induce and increase endogenous production of ceramide. So this product is not necessarily adding the 3 essential ceramides like Cerave does, but it is trying to induce the skin to produce its own essential ceramides. When we look at the Cerave AM and PM products, and these are some that I recommend very frequently, all of these I recommend, but these moisturizers in particular are high on my list. We know that the AM has the SPF, the PM is higher in the humectant. Niacinamide is also there as an anti-inflammatory and barrier repair, barrier support ingredient. The emollient is dimethicone as lipid-free cleansers, and we see barrier replenishment with that 1362 that I mentioned before. We also see there the MVE, the multivesicular emulsion. This is the oil and water emulsion where the barrier replenishment ingredients are released slowly over time. So this is a delayed release format to give long-lasting hydration and emollients and barrier replenishment when these products are used. Neutrogena has the Hydro Boost Gel Cream. It has humectants as shown with an emollient of dimethicone and synthetic beeswax. And that dimethicone, of course, is that moisturizing ingredient as well. And then the humectants in the Neutrogena oil-free facial moisturizer has the anti-inflammatory with soybean oil. So here, as I thought about the decision-making framework for moisturizers, I decided on three major metrics: the moisturizing capability, the anti-inflammatory, repair. Moisturizing being related to the use of lipids or petrolatum, or that's silicone or dimethicone. Anti-inflammatory, be it niacinamide or the zinc or the licorice extract, for example, and the barrier repair being the replacement of the ceramides. I also thought about how we would utilize these products in terms of a retinization timeline, whereas early on with the use of a retinol or retin A product, to keep our patients using the products so they don't get so retin inflamed. Later on, as the retinous inflammation may wane, we are more interested in barrier repair because we know that the retinoids can affect the barrier as well. And so you see here the Cerave AM, I thought really hit the high points with moisturizing, anti-inflammatory, and barrier repair. Cerave PM, that pink was high as well, perhaps because of the higher niacinamide content in the AM. I gave that a little bit of a higher score than the PM, although the PM has the higher humectant. And then the Hydro Boost and the oil-free just don't have the ingredients to really compete with the increased moisturizing and barrier repair capabilities of the other products listed. Okay, then when we move on to cleansers, whereas moisturizers seek to add natural ingredients back, cleansers have perhaps a more difficult job of removing natural and chemical substances, but leaving the natural lipids behind within and between the corneocytes. So remember what a surfactant is. It's a surfactant, a surface active agent. It lowers the surface tension between two substances. It's got that hydrophilic head with the hydrophobic tail that are grouped together to trap the oil in the middle within an aqueous solution. A micelle is a mild surfactant with charged and non-charged ends, with the molecules aggregating within a colloid solution. So when we think of micellar water, it's really just a soft water with grouped, very mild surfactants in the micelles. The optimal cleanser removes sebum and debris, but as I mentioned, preserves intracellular lipids, and I would even say helps to moisturize as well, so it can do more than just cleanse. When we think about surfactant activity, we want to see them as polymers. We want to see their surfactants grouped together, because when they are released as monomers, that's when they can get between the dead corneocytes and cause an issue with the lipid bilayer and remove those lipids which we so dearly want, especially that healthy cholesterol ceramide free fatty acid ratio. So what we want is polymers of cleanser surfactant. And in fact, there is this hydrophobically modified polymer, HMP, that was developed, which helps to group the surfactants together and the micelles together into larger stable structures that are less likely to penetrate the stratum corneum. And we'll talk about that with one of the products we have as well. Dr. Kursick touched on this. We know that the soap has a very high pH. Remember, soap is just a fat and an alkali. It's beef tallow and lye. That's how it was first formed. It's a fatty acid salt. It's got a high irritancy potential, but it's got a high cleansing ability as well. Ivory soap being an example. And as we move down, what we see is essentially a maturation of the cleanser technology. Whereas, before we had soap, which was very irritable and changed the acid mantle of the skin. Now we have these lipid-free cleansers, which are neutral to acidic and contain no real soap, but have surfactants and otherwise have humectants and moisturizing capabilities as well. So while their irritancy potential is essentially nil, they do have cleansing ability because of these synthetic detergents contained. Lipid-free cleansers, Cetaphil Pro, I thought it would be good to stay within the Cetaphil Pro line. It has that zinc, again, we see that as a surfactant and antibacterial and foaming. Now, what you'll notice is those ingredients which foam have higher levels of surfactants. That's what allows them to foam. Higher levels of surfactants, of course, can cause more issues because they can cause loss of lipids between the cornea sites. We have to be careful with foaming face washes, in my view, especially with those patients who are sensitive or are on a retinoid. The Cetaphil Pro has a humectant as glycerin, and the anti-inflammatory, again, is the same as we saw in the lotion with the licorice extract and the zinc gluconate. Then the Serum Dehydrating, this is another one of my go-tos. It has the slight foaming capabilities with those surfactants. The humectants are listed there. Of course, it's got the 3 essential ceramides that we see in all the Cerave products. And then we have the unique property of that multivesicular emulsion technology, which I touched on previously, to give a slow release of moisturizing ingredients over time. So this is both taking away the sebum, which is pro-inflammatory, the debris, but it's also allowing the barrier to be repaired via the ceramides that are left behind. In addition to the hydrating, we've got the Cerave foaming cleanser. This would be more for your very oily patient, for example, that could tolerate the higher surfactant content. Again, it does leave the moisturizing capabilities behind with the ceramides, and it has niacinamide in that. So if you were thinking of your oilier teenage boy patients or perhaps adult with the sebaceous skin, the foaming facial cleanser would be a good one to consider. The Neutrogena Ultra Gentle Daily Cleanser is interesting because of that HMP technology that I touched on before, where the surfactants are grouped together into large polymers, and it reduces the availability of the monomers to penetrate the skin's surface. Okay, so the decision-making framework for cleansers, we talked about, the cleansing strength, the irritancy potential, and the tolerability. And the tolerability, in my view, is really linked to the barrier repair capabilities as well. And we see that, of course, cleansing strength ties in with the irritancy when we think about ivory soap, which is our traditional soap, but of course it has very low tolerability. When we start talking about some of the others, you have to go on the other side of micellar water, which has great tolerability, but the cleansing strength is going to be low, and that ties in with the irritancy potential as well. In between those two poles, we have multiple products that I tried to classify, and you can see where we have the Neutrogena Ultra Hydrating with the tolerability and the good cleansing and low irritancy potential, and then we have other products that fit right in there. The Cerave Foaming and the Cerave Hydrating are right in there. I have the Cerave Hydrating as having a little bit of a lower cleansing strength than the foaming, just because of the lower number of surfactants there, but certainly has excellent tolerability and low irritancy potential as well. So that's how I think of how I classify that bottom shelf in my sample closet with these decision-making frameworks for moisturizers and cleansers. And of course, we have oiliness and sensitivity there as well. And with that, I'd like to end the talk, and I'd like to now introduce our next speaker, Dr. Kulthanan, who is a professor of dermatology in the Department of Dermatology and the Faculty of Medicine at Siriraj Hospital in Bangkok, Thailand, as well as the president of the Dermatological Society of Thailand. It's about 7:30 in the morning in Bangkok right now, so we have a very fresh-faced and ready to go Dr. Kulthanan to enlighten us with her wonderful talk. So thank you so much.
Thank you, Dr. Lin, and hi everyone. Good morning from Bangkok. So I'm going to talk about acne in Asian skin. This is an epidemiologic study of the prevalence of acne vulgaris in women among race. The prevalence of acne vulgaris in Asian women was 30%. And you can see from this figure that all race groups display equal prevalence of both subtypes of acne, inflammatory and comedoned, except Asian, whom inflammatory acne was more prevalent than comedoned. Here you see acne lesions in Asian women, closed and open comedoned, erythematous papules, pustule, and nodulocystic lesions. Acne lesion in Asian men on the face, upper back, and this man got nodulocystic acne and scar on his chin and neck. Asian skin has many differences compared to other skin types, so require different care methods. Asian skin is oilier, easy for acne to develop, more sensitive and more prone to irritation to certain topical agents, and loses moisture more easily. Asian skin more prone to develop post-inflammatory hyperpigmentation or PIH when inflamed or injured. This is a study comparing skin irritation between Japanese and European women using patch tests on the forearm with sodium lauryl sulfate and also a stinging test with 10% lactic acid. No significant difference of barrier function, but significant subjective sensory difference. So here you can see that Japanese women may complain about stronger sensations. Another study compared skin barrier-related parameter of stratum corneum on African American, Caucasian, East Asian skin by objective measurements. Baseline value of transepidermal water loss were measured on the face, and consecutive stratum corneum D squame 1 tape stripping were collected on the patient's ventral forearm and face to evaluate skin barrier strength and cohesion. So the results show that East Asian skin had low maturation and relatively weak skin barrier, and this can imply in terms of increased skin sensitivity. A large multi-center trial in China, data on history of acne and self-evaluation of the skin were collected using a questionnaire. Clinical evaluation was carried out by dermatologists, and sebum secretion was measured using sebumeter. The results show that oily skin prevalence was 26%, and one of the parameters associated with oily skin was highly reactive or sensitive skin. Here another study compared the irritation of adapalene gel and with tretinoin. Healthy volunteers of various ethnic origins applied adapalene and tretinoin daily to the face for 3 weeks, and we evaluated for the level of irritation. So you can see that the irritation potential of adapalene was significantly lower than that of tretinoin gel in all tolerability assessment, irrespectively of volunteers' ethnic origin. However, statistically significant differences were observed in the facial signs, with Asian skins being more susceptible than Caucasian. This figure shows skin microbiome in Asian patients with acne vulgaris. Skin swab from 9 healthy controls and 67 acne patients were collected, and skin microbiomes were analyzed using ribosomal RNA gene sequencing. So you can see that compared with healthy control, acne patients harbor significant altered skin microbiome. The skin microbiome of patients with grade 1, 2, and 3 acne were similar, but the patient with grade 4 acne, which is severe acne, show a significant difference from grade 1, 2, and 3, and increased proportion of 4 gram-negative bacteria. This is a review study using double-blind placebo-controlled study of benzoyl peroxide monotherapy performed in Western country and compare with 2 reports of Japanese study selected by the same criteria. So the results show no differences in the efficacy of benzoyl peroxide. The incidence of adverse events was higher in Japanese patients, but the characteristic was not different. As we know that patients with darker skin types, acne is often accompanied by post-inflammatory hyperpigmentation, And PIH can cause greater concern for a patient more than the acne lesion itself. So this study includes more than 300 patients consulting dermatologists for acne and evaluated for the presence of PIH. Here you can see the result. 60% had PIH, and pigmentary problems will often last long. The patient reported that PIH was quite bothersome and often as bothersome or more bothersome than the acne itself, and excoriation was common. This is an example of our patient, female, 24 years old, received oral doxycycline together with topical benzoyl peroxide and clindamycin, and the patient had dry skin after topical acne medication and post-inflammatory hyperpigmentation. Another one, female, 22 years old, received oral isotretinoin together with topical benzoyl peroxide and clindamycin. Again, this patient got dry skin and PIH. For female acne, which is a different subtype from teenage acne, most frequent recognized was 25 years old, and most of the patients had mild to moderate severity, and the lesion mainly affects face. Here you see Asian adult female acne patients. On your left-hand side, female, 25 years old, had acne onset since 15 years old, so she had persistent acne. In the middle, female, 32 years old, she got acne since 27 years old, so she had late onset acne. And on your right-hand side, female, 38 years old, she got acne since puberty, and acne disappeared for many years, then returned when she was 26 years old. So she had relapsed subtype of female acne. We performed a community-based questionnaire study in Thai students to study their opinion and perception on acne. Nearly 600 students from 5 randomly selected high schools in Bangkok were asked to fill a self-reported questionnaire about acne and then further examined by dermatologists to grade acne severity. So the results show female predominate with the mean age about 15 years old. More than half believe that inadequate sleep, stress, sweat, exercise, hot weather, cosmetic, premenstrual period, oily food, and sun exposure aggravated their acne. For quality of life, we have studied 110 acne patients attending our outpatient department and assessed clinical severity of acne scar, and the patients were asked to fill the LQI questionnaire. The first episode of acne was present from the age of 10 up to 31 years old, with a median of 15 years old. The most common site of acne lesions was face. 2/3 of the patient had oily skin, and 30% had mixed type of oily skin on central facial area and normal skin on cheeks. Question about embarrassment, you see in this figure, question number 2, had the highest mean DLQI score, which means greatest impairment of quality of life, followed by social activity and itching. When we separate patients into low and high DLQI score by median DLQI score, my acne patient, most of them had low DLQI score, but some patients still had high DLQI score, which implies that even my acne can cause significant problem to some patients. For severe acne, most patients had high DLQI score, but some still had low DLQI score, which implies that some patients were not concerned with their acne. This is the Southeast Asia Study Alliance guideline on the management of acne vulgaris in Southeast Asian patients. You see that the treatment steps are similar to other guidelines in Western countries. So, importance of skincare in improving adherence in Asian acne patients. For facial cleanser, evidence in Asian population show that appropriate facial cleansers are useful in acne treatment. So we recommend washing the face with a mild cleanser that can produce significant improvement in skin of patients with acne. The ideal cleanser should be non-comedogenic, non-acnegenic, non-irritating, and non-allergic. And it should be suitable for patient's skin type. May contain active anti-acne ingredient. For moisturizer, we recommend patients to use appropriate moisturizer by the evidence that moisturizer do not affect the efficacy of topical acne treatment, improve stratum corneum water content, and reducing the sensation of dryness. It can prevent and treat dryness and irritated skin due to acne treatment, improve local tolerance to topical treatment, and improve adherence. But it should be water-based, non-greasy, non-comedogenic, non-acnegenic, and hypoallergic. And the last recommendation is sun protection, which is an important adjuvant treatment in acne treatment to prevent PIH, to reduce further dermatitis due to oral and topical retinol use. Sunscreen formulation should be clinically appropriate for use in the management of acne-prone skin. Broad spectrum, non-comedogenic, water-based or light liquid-based to avoid irritation. So I thank you for your attention. So next, I will hand over the screen to Dr. Kersik again. He will tell us more about skincare products. Dr. Kersik, please.
Thank you so much. So for the next 10-15 minutes, I'm gonna take over from where I left and where all the other speakers actually left, how they mentioned the importance of the over-the-counter product partnership with the treatment of acne, but how to choose which product. As Dr. Lane mentioned, it does become difficult. And I think I just wanted to again bring back the Dr. Ellen Larson's from Columbia University's notes and the disease control paper here about the soaps and the pH. And I think that's really important. But you know, the question is very simple. Which cleanser would you pick? Well, as I mentioned, the pH is important. So you would pick the neutral pH or pH balanced product. And here we can see that on the top of the pH 5, here we have Cerave Hydrating Cleanser Bar and Cerave SA Cleanser. So really it is not that difficult which one to pick, as long as we know that the pH of the skin is important to keep the neutral pH, and which product is going to keep that. Here you can see the numbers and it's very self-evident. Also, there's a new product coming from Cerave Hydrating Cream to Foam Cleanser with a pH of 5 that gives you a little bit of that foaming sensation, which most of the patients want, even though you really don't need that foaming for cleansing purposes. But 99% of all my patients, including my wife, she thinks that despite what I say, you don't need that foaming and sudding in order to cleanse. But again, that's a perception. So it does help to have that a little bit of that sudding, foaming sensation. Now, then, what do we do when we have the dry skin? Well, we have the dry skin, we really get the moisturizers to the rescue, right? And that is going to help to repair that epidermal barrier and the broken epidermal barrier, the broken wall. How do we fix it? Of course, we fix it with that moisturizer. Now, what is the missing product there? We know that ceramide, 50% of the lipid mortar is the ceramide. So you do want to replace the ceramide. But what differentiates one ceramide containing moisturizer from the other one? That's the key question, because you know, as As Dr. Lane showed his sample cabinet, there are several moisturizers, and almost all of them have ceramide in it. Why would you pick one against the other? That's the key question. So whenever we have a ceramide containing product, are they all the same? Is there a difference? That's not true. Not every moisturizer, not every ceramide containing moisturizer is equal. We have to understand the delivery, and that's where the keyword comes in here. The vehicle does matter. And if you look at the Cerave ceramide blend, first of all, there are 3 ceramides, human skin identical lipids, and additional lipids. But the most important thing is it is not the ceramide itself. It is it going where it's supposed to go, or is it sitting on the skin? That's the key question here. So let's take a look what's unique on the Cerave products. We already discussed the key ingredients. We know that there is niacinamide, which is very hydrating. It also helps, however, to increase the production of the natural ceramides. But most importantly here in the Cerave products, it's the unique delivery technique, multivesicular emulsion technology. That's the key that I want to emphasize, the unique delivery. Why is it important, or what does it do? Let's take a look what does that delivery brings to us. So first of all, if you look at your traditional emulsion, it's a rapid release, right? The things come out very fast. And this is unique. It's not unique to a moisturizer. It's unique to anything that any drugs, right? We have delayed release medications versus rapid release medications. We know that very well in dermatology. So when you look at this 2-phase oil in water emulsion, in this case, it consists of concentric spheres of oil and water phases. And this is maintained by a unique molecule called BTMS, or also known as behentrimonium methylsulfate. It's a cationic surfactant. It's both dispersible in water and oil. And that's the key word here. It's dispersible both in water and oil. It's actually derived from the rapeseed oil that you can see here, the picture. And when you look at the traditional emulsion, it's just a burst release. Whatever it's in that, it's going to open up and come out right away. Versus when you look at that multivesicular emulsion, it's almost like what I call this little Russian dolls that you buy in Moscow on the streets, right? It's like a souvenir. That what happens is slowly each one of them opens up, and every time you open one, then the other, a little one comes out, and little one comes out. It's the same idea with the multivesicular emulsion technology, that you open these little spheres, or it's almost like the onion wrap, right? And then each one of them opens up slowly over 24 hours, rather than in a burst delivery where you have everything in a couple of hours and then you don't have any more moisturizing effect. So in this case, you have a 24-hour long-lasting moisturizing effect, which is the key. And you can see that here in the light microscopy, magnified 100 times more. So basically that shows you that little spheres in one another. The other thing that we have in Cerave, which is very important, and Dr. Lane actually did mention the importance of different type moisturizers, dimethicone, which is a occlusive moisturizer, and glycerin, which is a humectant, which you need both in order to have a complete moisturizing system. Otherwise, if you can occlude the dry epidermis, nothing is going to happen. You keep it dry. Or if you just bring the humectant and bring the water or humidity from the deep layer of the skin, and if you don't have an occlusive moisturizer, it's going to evaporate as fast as it comes. You're not going to do any good to anybody. You need both in order to accomplish what you want to accomplish. So now I want you to think a little bit of the acne patients that we're treating them with topical retinoids, so drying, so irritating, topical antibiotics, benzoyl peroxide. Those are the mainstream topical treatment options that we have, and we use it. But unfortunately, it does make the patient worse in the beginning. We know that the first 2 weeks, the topical retinoids peak at their irritation. You have to do a lot of hand holding, but more than the hand holding, you can help the patient with the correct partner here, with the right partner, with the moisturizing and the gentle cleanser at the appropriate pH balanced treatments. So as we heard before from the previous speakers, that appropriate partner is very important, has to be pH balanced. Now, it becomes even more relevant at the COVID times when this poor patient is wearing the mask and irritating even more. Can you imagine to put the topical retinoid and then put the mask on? So now the irritation level doubled. So as we already heard, there are several studies that does show that appropriate partner and adjunctive treatment helps not only actually mitigate the irritation, but also increase the compliance, right? That's very important. So there is one study from Dr. Josh Zachman at Mount Sinai, my good friend, that they did a study with basically fixed dose clindamycin phosphate benzoyl peroxide gel in the morning with a combination in the evening of tretinoin and ceramide containing moisturizer, in this case Cerave. And you can see that it did help the patients improve the acne regimen tolerability, which in return, by the way, it means that compliance goes up, right? Because if you don't help the patient increasing tolerability, they are not going to be able to use the treatment and they are not going to get better. So it's almost like a chain effect, right? One leads to another. There was another study that we already heard about, the Canadian consensus paper with Chuck Lind, another good friend of mine from Toronto, very good excellent dermatologist, and from his group, and I think Dr. Lane also mentioned this, that they looked at, again, ceramide containing moisturizers, Cerave here in this case, and it did help compliance as well as the tolerability. That's the whole point here, be able to increase compliance with this difficult acne treatment, especially with the retinoids, and then increase the tolerability. So let's take a look what is in the Cerave products here. With the hydrating cream to foam cleanser, we have the 3 essential ceramides, we have the MV technology. In addition, we have the amino acid hyaluronic acid functioning as humectants. With the foaming cleanser, same there, and additionally we have niacinamide, which is a moisturizer as well, antioxidant, but also it does help to increase the natural production of the ceramides, which was a very interesting study. And then we have the PM Facial Moisturizing Lotion. Again, it does have the 3 essential ceramides with the MV technology and hyaluronic acid. So basically, the cleanser, the hydrating cream to foam cleanser, and the moisturizing lotion with the MV technology, that is the unique delivery system that I want to keep emphasizing. Most importantly, all of these products are soap-free, fragrance-free, non-comedogenic, allergy tested, but pH balanced. They all have natural skin pH somewhere around 5 to 5.5. So please do not forget the acid mantle and the skin pH. The natural skin pH is acidic, and we have to keep that for success. And barrier repair is a must as an adjunctive therapy, as we already heard, regardless what the condition is, but it's even more important now with the COVID, indirect impact of the COVID. So I'm going to stop here, and we have one polling question. So is there a benefit in ceramide over-the-counter skincare for acne patients? Yes or no? So everybody said 99%. I think our job is done here. Now we can all go home. Thank you so much. I think we're gonna stop here. We do have a Q&A session. I do want to thank, however, for your attention on behalf of all the speakers. And if we cannot answer any of the questions within the next 5 minutes or so, please feel free to write to me at wedoderm@yahoo.com. I will be more than happy to answer each and every one of the questions that you have. Thank you.
Thank you, Dr. Kursik. I just want to remind everybody that the recording of this important meeting will be emailed to you 1 to 2 days later, so you can listen to it again at your leisure. It's also available on cerave.com and rbcconsultants.com. Again, if you have any questions, please submit them in the question chat pane on the right-hand side, or you can also submit them afterwards to info@rbcconsultants.com. Again, thank you for our supporter, Cerave, that's made this educational event possible. So let's pass on to a couple of questions. So the first question to our faculty, perhaps Dr. Kursik, what is the pH of Cerave moisturizer and cleanser?
So they are around, they have the natural acidic pH of the skin very close, somewhere around 5.5.
Okay, thank you. Dr. Lane, what should be the first thing you put on, the moisturizer or the prescription product?
Isn't that $1 million question? I think it depends on the prescriber and the patient's preference. I tend to put the therapeutic on first, so I put on the prescription product first and then apply a moisturizer. But then I have multiple colleagues, as well, the other panelists here can attest to that, who tend to mix the products together. I tend to avoid that because we don't know the chemistry of mixing or the absorption capabilities of mixing, so I tend to layer.
So I'm gonna chime in there, Ted. Actually, you know, inherently, absolutely, I was taught that you first put the medicine on, then you put the moisturizer, right? So years ago, we did a study, ironically with Cerave. It was Dr. Tangeri and myself, and I think Dr. Del Vaso, with Tazaratan, with Tazorac for acne. And what we did was first apply the moisturizer and then apply the Tazorac, which is, as you know, one of the most irritating retinoids, even though it works really well. And then the other face got the Tazaratan first, and then the Cerave. And believe it or not, there was no difference in efficacy, but there was much better tolerability with the group that got the moisturizer first, which goes totally against everything inherently we believe and understand, that yes, you have to put the medicine first, but really it didn't make a difference.
Yeah, there you go. So I'm not sure that there's a 100% right answer there. So it goes to preference.
Yeah.
Dr. Kulfanan, what would you say are the key issues in acne in Asian patients?
So as I have already talked, but I would like to summarize that overall main concern of Asian patients are post-inflammatory hyperpigmentation. So you know that many Asian patients want to have white skin. So they concern a lot about the sequelae PIH. And another point is relatively sensitive skin. So this should be taken into account when you treat acne in Asian patients.
Thank you. One question perhaps for Dr. Kursik. What happens when you increase the pH of the skin?
Sorry, I missed it, Roxanne. What's the question?
What happens when you increase the pH of the skin?
A lot of bad things will happen. So if you increase the pH of the skin, you are basically decreasing the ceramide and other lipid formation, because you are slowing down the converting enzyme from the precursor lipid to the final lipid. You're also increasing the breakdown of the corneodesmosomes, because the breaking enzymes are working faster and better at the neutral pH, and hence now you are really impairing the epidermal barrier, just to summarize, and hence creating more inflammation, more irritation, increased transepidermal water loss, decreased hydration.
Thank you. Can Dr. Lane elaborate more on the humectant concept? Humectants are prevalent throughout the skin, so are you suggesting that this category of ingredients are helpful for the skin barrier?
Well, absolutely. I mean, they support the skin barrier. They're part and parcel of what the skin barrier is about, right? So humectants draw hydration into the skin, into what we consider the stratum corneum, the upper layer of the skin, primarily from the lower layers of the epidermis and dermis, except if you're in a very tropical climate. And so they're part of the barrier. In fact, the barrier's idea is to maintain the hydration of the skin. So if you don't have sufficient hydration to maintain, then the whole idea of barrier repair kind of goes by the wayside. So you have to have, as partners, humectants with barrier repair ingredients Otherwise, you're going to get too dry and barrier repair won't help at all. You won't have enough moisture.
How many times per day do you recommend patients with acne to apply moisturizers? Dr. Kulthanan?
I think there is no exact rule. It depends on the patient's skin type, age of the patient, and types of topical anti-acne medication. I think so. For example, you can apply water-based or non-greasy moisturizer once daily if it is the photoprotective moisturizer in the morning, for example. But it can be used as often as necessary to reduce the drying and stinging effects of topical acne treatment. So, Dr. Len, what do you think?
Yeah, no, I totally agree. I think what's difficult for acne patients is that many of them have an oily complexion, and so it's difficult for them to understand the concept of applying a moisturizer to an oily complexion, and therefore it's imperative that we, when we have our patients in our offices, we explain to them that this oily complexion is not necessarily doing their skin very good. In fact, it's part of the reason that they have acne, and it's pro-inflammatory. We need to reduce their natural oils because they're altered, and we need to replace them with those ingredients that will actually help the skin and reduce their acne. So I agree. I don't know that there's a right answer, but I think part of that question lies with education for our patients and understanding the natural oils that they're producing are not the right oils for their skin.
However, if I can chime in, Roxanne, for a second, absolutely, that's correct. On the other hand, if we think about the Cerave with its multivesicular emulsion technique, which actually does provide 24-hour moisturizing versus any other moisturizer that, it's maybe 2, 3, 4 hours, it's gonna be there. So, and we all know that our patients are non-compliant, and including myself, I don't wanna apply something 10 times on my face. Why not to have something that we do have that multivesicular emulsion long-term delayed release over 24 hours versus something that's just gonna be there for 2, 3, 4 hours. So I think that's a big advantage.
Yeah,
absolutely agree.
Dr. Kulthanan, how to prevent and treat PIH on Asian skin?
So actually, PIH almost always occur in many patients. However, one of the important point is sun protection. So if you don't expose too much to sunlight, PIH will appear less intense, and it will disappear faster.
Thank you. Maybe Dr. Kursik, at the beginning you were talking about maskne. How does a mask exacerbate acne in patients?
Well, definitely all those masks have irritating effect on it with the rubbing and the scratching on the face. I mean, I don't have acne, I'm not using retinoids, but I just arrived from Maui. I was on the plane for more than 24 hours with the mask on my face. I'll tell you, it's quite irritating. So definitely it does irritate, and with the irritation, the epidermal barrier and transepidermal water loss increases, the epidermal barrier is impaired.
Dr. Lane, what is the role of toners? Any recommendations?
Toners are an interesting product. When soap was not pH balanced to the skin, toners were important to reset the skin to the correct acid mantle pH, and so they definitely played a part. Nowadays, as we've heard about from Dr. Kursik in particular, the cleansers that we should be using for our acne patients are pH balanced, and so we don't need the toner for that purpose. However, toners can be an additional layer of cleansing. Many patients like the astringent properties of toners where they feel their skin tight. It's a very different feeling than when they have the oil on their skin. So I tend to stay away from toners personally for my acne patients, especially because I'm already using therapeutics. And so I'm worried about over dryness with toners, although certainly if you are recommending a purely OTC regimen for your patients, perhaps a toner may be a good idea for that very oily patient in particular.
And another question for you, any over-the-counter options for post-inflammatory hyperpigmentation?
Yeah, I mean, Dr. Kultanan touched on this. Certainly, SPF is extremely important, at least 30, often higher for my patients dealing with PIH. There are multiple ingredients that can deal with PIH over the counter. Niacinamide is actually one of them. In addition to that, you've got kojic acid, you've got licorice extract. There are multiple. So certainly I would look at those that are called brightening products. They will contain those ingredients that will help brighten the skin. And then you can often find a 2% hydroquinone over the counter as well. We just have to be careful, of course, with those products, but there are options.
Great, and I guess an overall answer question for our panelists, what would you say are the key issues in acne in patients of color?
So maybe I'll take that first, since almost more than 1/3 of my patient population is African American, and they are really more concerned. It's ironic, when they come to me, they are more concerned about the quote-unquote blemishes rather than the acne itself. And so it's the hyperpigmentation is a big issue, because in all honesty, acne comes and goes, but what lives behind is devastating. And post-inflammatory hyperpigmentation, it's a big problem for patients of skin of color. And so what I try is, at this, I'm so careful to avoid post-inflammatory hyperpigmentation, as we know that topical retinoids by irritation may also cause, in the beginning of the treatment, post-inflammatory hyperpigmentation, which is a vicious cycle, because we use them to resolve the PIH, but then in the beginning, sometimes we actually do cause it. So this is where all this adjunctive treatment, the gentle cleanser, the moisturizer, comes to the picture. And it is so important to be able to sell the whole treatment regimen. And I'm using the word sell because patients really don't pay attention to the moisturizer, right? That's over-the-counter stuff that they think they are not in the doctor's office for that, which they can get it themselves from the shelf. But the importance of, I think, the explaining and the education of the importance of the education with the whole acne treatment regimen that we know as dermatologists, but they don't, becomes really important.
Yeah, Roxanne, if I might chime in as well, I think one of the hardest things, just as a dermatologist, in the room as you're evaluating an African American or darker skin patient, is assessing the inflammatory lesion. Sometimes you'll have PIH already there to give you the idea that there is inflammation, but otherwise it can be very difficult to assess an inflammatory lesion versus a closed comedone, for example. And some of the ways you could do that is literally by touching the face, because they feel very different. So I would urge those who are assessing your darker skin patients to touch, feel, use your senses, because it can be very revealing in determining what's inflammatory versus non-inflammatory, and that may inform your decision making regarding your therapeutics and your OTC adjunctive therapy.
Dr. Kultanan, any final word?
So I think I would like to add a little bit about post-inflammatory hyperpigmentation in Asian. So this is a great concern. However, if we try to reduce inflammation at the beginning, so we think that it will help some patients to reduce the occurrence of post-inflammatory hyperpigmentation, or in another words, it will reduce the intensity of hyperpigmentation. So perhaps this is another way to help the patient, besides sun protection, which is a general recommendation to prevent PIH. So I think so.
Thank you. Well, Dr. Krusik, Dr. Lane, Dr. Kultanan, thank you so much for this great presentation and really relevant to today's environment. And thank you all for joining us this evening. Good night, everybody.
Good night. Bye-bye.
Good night. Thank you.
And good morning.
Good morning.
Bye.
Bye.